Welcome to the NYU Meyers World AIDS Day event, sponsored by the Upsilon chapter of Theta Tau International. I am Dr. Ann-Margaret Navarra, Associate Professor at NYU Meyers College of Nursing, and will be serving to moderate today's presentation entitled Accessing Equity in HIV Care. Our speakers include Dr. Michael G. Rosenberg and Dr. David Ray Garcia. Dr. Rosenberg is an Associate Professor of Clinical Pediatrics at Albert Einstein College of Medicine, an attending physician in the Division of Infectious Diseases, Department of Pediatrics at Jacobi Medical Center. He is a Fellow of the American Academy of Pediatrics, member of the Infectious Diseases Society of America. Dr. Rosenberg has been actively engaged as an investigator in a multitude of NIH-sponsored studies and currently serves as a site investigator for the NIH-funded Access to trial. Dr. Rosenberg widely disseminates research findings and clinical scholarship and leverages his expertise through teaching and active mentorship. Dr. Rosenberg was most recently acknowledged for his leadership as the recipient of the Henry Barnett Teaching Award at Jacobi Medical Center. Dr. Rosenberg is an expert in pediatric infectious diseases and has provided medical care to children, adults, and families living with HIV for nearly 30 years. We are honored to have Dr. Rosenberg join us today. Dr. Garcia is the NYU Provost's Postdoctoral Fellow and Assistant Professor at NYU Meyers. He is a double board certified family nurse practitioner specializing in men's health. Dr. Garcia's interdisciplinary research focuses on the syndemic associations between substance use, violence, mental health, and HIV risk behaviors among adolescent gay and bisexual men, and the protective factors that mitigate these risks. Of note, Dr. Garcia was the recipient of the Distinguished Dissertation Award for his completed dissertation entitled Syndemic Predictors of HIV Risk Behaviors Among Adolescent Gay and Bisexual Men, a secondary data analysis of the Youth Risk Behavioral Survey. We are grateful to have Dr. Garcia with us today. Before we begin our presentation, I ask you to mute your microphone. These presentations will be followed with time for scholarly discussion and dialogue. So let's get started, and please join me in warmly welcoming Dr. David Garcia.
All right, thank you, Dr. Navarra, and welcome again to everybody online this evening as we commemorate World AIDS Day 2022. This year marks the 35th World AIDS Day, and this year we look towards achieving health equity to address the persistent health disparities and drivers of the HIV epidemic. The objectives for this opening presentation are to provide an overview of World AIDS Day, some basic epidemiology of HIV, discuss achieving health equity in HIV care, and our domestic roadmap for ending the HIV epidemic. Then we will hear a presentation on antiretroviral therapy, past, present, and future, and cure by Dr. Michael Rosenberg, Division of Pediatric Infectious Diseases at Jacobi Medical Center. Before we begin tonight, our team of research scientists in the Access to study developed this slide to acknowledge the path that we have been through in HIV/AIDS and the direction in which we are going. This year, we observe World AIDS Day in the context of two other disease threats, COVID-19 and monkeypox, which requires that we continue to address health equity through a holistic lens, and being aware as healthcare providers, community health workers, and allies that there are many social needs that contribute to health equity. As such, UNAIDS calls for practical action to address the HIV inequities that continue to persist. The World Health Organization defines health inequities as differences in health status or distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. The concept of health equity involves a state in which every person has a fair and just opportunity to attain their full health potential. And inequities are rooted in systemic and structural factors that limit access to power, opportunities, and resources for economically disadvantaged groups. Systemic and structural factors such as structural racism create obstacles to health and can result in persistent health inequities. This is exemplified by global HIV estimates that show 1.5 million people have newly acquired HIV, a decrease of 53% since the peak of 3.2 million people in 1996, and 38.4 million people are living with HIV. Also, another 650,000 deaths have occurred from AIDS-related illnesses, a 67% decrease since the peak of 2 million deaths in 2004. However, 28.7 million people accessed ART in 2021, and 81% of pregnant women living with HIV accessed ART and prevented vertical transmission. As we navigate through the global HIV epidemic, there is still much progress to be had in achieving targets of diagnosing 95% of people living with HIV, treating 95% of people living with HIV, and viral suppression of 95% of people living with HIV. In the United States, HIV incidence remains highest among gay, bisexual, and other men who have sex with men. The estimated number of new HIV infections nationwide has been trending downward, and in 2019, the number of new HIV infections was just over 34,000 people. However, as you can see with the dotted line on the right, our national goal is to decrease the number of new HIV infections by 75% by the year 2025 and 90% by the year 2030. However, stark differences by race and ethnicity continue to persist, particularly among Black and Hispanic groups. We are also trending upwards regarding the number of people living with HIV who have received an HIV diagnosis. In 2019, 87% of people estimated to be living with HIV have received a diagnosis. And as you can see with the dotted line on the right, our national goal is to increase knowledge of HIV status to 95% by 2025. Again, when we look at race and ethnicity, we see that people of color were less likely to have knowledge that they were living with HIV. The number of people living with HIV who received treatment remained flat at 82% in 2022. However, data is reflective of the barriers from the COVID-19 pandemic. And as you can see with the dotted line on the right, the US goal is to increase leakage into care to 95% by 2025. By race and ethnicity, we see that Black and African American individuals were among the lowest of all racial groups to have received medical care for their HIV within 1 month of diagnosis. The number of people living with HIV who are virally suppressed remained steady at 65% in 2020. As you can see with the dotted line on the right, the US goal is to increase the number of people living with HIV who are virally suppressed to 95% by 2025. By race and ethnicity, again, we see Hispanic, American Indian, Alaska Native, and Black individuals had the lowest percentages of viral suppression. Addressing HIV inequities will require that we continue to strive to increase access and remove barriers to HIV services, such as treatment, testing, and prevention. Address stigma through the reforming of laws, policies, and practices that criminalize and persecute people living with HIV. Share technologies to enable access to important scientific advances in HIV treatment, and engage with communities to identify and address health inequities. As we emerge from the COVID-19 pandemic and enter the endemic stage, we must acknowledge that much HIV progress was impacted by COVID-19. Globally, there were 30 million fewer HIV tests administered in 2020, and in the US, the decrease in HIV testing resulted in a 17% decrease in HIV diagnoses, particularly among populations disproportionately affected by HIV, such as Black and Hispanic, gay, bisexual, and other men who have sex with men, as well as transgender individuals. This will require that we accelerate HIV testing to compensate for missed testing and diagnoses during the pandemic to meet the US initiative for ending the HIV epidemic. The US initiative for ending the HIV epidemic aims to reduce new HIV infections by 90% by the year 2030 through 4 strategies, which include diagnosing all people living with HIV as early as possible, initiating HIV treatment rapidly and effectively to achieve viral suppression, preventing new HIV transmissions using evidence-based interventions such as pre-exposure prophylaxis or PrEP, post-exposure prophylaxis or PEP, and syringe services programs or SSPs, and respond quickly to HIV clusters to deliver treatment and prevention services. Diagnosing all people living with HIV as early as possible will require encouraging people at substantial risk to test annually at a minimum, simplifying access to HIV testing, and partnering with communities to utilize innovative testing programs, such as HIV self-testing distribution programs, testing in mobile and non-traditional settings, and expanding capacity of frontline community-based organizations. There are two types of HIV self-tests: the rapid self-test, which is similar to what we saw during COVID-19, and mail-in tests, which require the sample to be sent to a laboratory. However, barriers to both of these is that they remain costly and out of reach for many communities. Initiating HIV treatment rapidly and effectively to achieve viral suppression is the second component of the Ending the HIV Epidemic initiative. People living with HIV who maintain an undetectable viral load have effectively no risk of sexual transmission to their partners. However, many barriers persist in delivering equitable treatment to populations in need and retaining people in HIV care. As such, 80% of new HIV infections are transmitted by people who are not engaged in care. Similarly, there is also a need for increased access to sexual health, as 7% of HIV infections are attributed to co-infections with STIs. The third component of the EHE initiative is preventing new transmissions using evidence-based interventions. There's a vital need for programs that address the unique needs of communities, such as the expansion of syringe services programs. Syringe services programs have been shown to reduce HIV risk and act as an entry point for drug treatment, overdose prevention, and prevention of infectious diseases. People who use SSPs are 5 times more likely to enter treatment for drug use and 3 times more likely to stop using drugs compared to people who don't use SSPs. From a syndemic approach, we know that substance use is associated with increased HIV risk. Other important interventions include mobile testing units, interventions that incorporate peer-to-peer relationships, and innovative delivery options for PrEP and PEP services, such as teleprep and same-day PrEP delivery. Though pre-exposure prophylaxis or PrEP has been a game changer for HIV prevention, less than 25% of the 1 million people who would benefit from PrEP have been prescribed PrEP, far less than the national goal of 50%. We also see stark racial and ethnic differences regarding uptake of PrEP among populations most in need, such as Black and Hispanic gay and bisexual men and Black women. Indications for prescribing PrEP, according to the New York State Department of Health AIDS Institute, are fairly simple for clinicians and indicate that clinicians should recommend PrEP for individuals, including adolescents, who do not have but are at risk for acquiring HIV. Clinicians should prescribe PrEP for individuals who self-identify as being at risk for acquiring HIV, and clinicians should recommend initiation of PrEP immediately after the completion of PEP when patients remain at risk for HIV. Candidates include those who have sexual partners with unknown HIV status or are not virally suppressed, have anonymous sexual partners, have partners at high-risk venues, have partners involved in transactional sex, have been diagnosed with STIs in the last year, report substance use during sex, and inject substances including silicone or hormones, or anticipate risky sexual behaviors. Formulations for PrEP currently on the market include 2 oral formulations that are once daily regimens, as well as injectable PrEP, which is injected in the buttocks every 2 months in a medical office. The fourth and final component of the EHE initiative includes rapid response to HIV clusters in order to deliver treatment and prevention services to populations experiencing rapid HIV transmission or outbreaks. We know that over 60% of new HIV diagnoses among Black and Hispanic people occurred in just 57 priority jurisdictions. So we have the roadmap already. But halting onward transmission of HIV infections will require community collaborations between healthcare providers, people living with HIV, community advocates, community-based organizations, and community leaders to reach networks that are experiencing rapid HIV transmission. This will require engagement with people who have undiagnosed HIV, people living with HIV who are not currently receiving treatment, and people who would benefit from HIV prevention with PrEP or HIV testing. Community health workers remain vitally important to HIV care. States with the highest employment level of community health workers include New York, California, Texas, Washington, and Massachusetts. Besides their many titles, the roles of a community health worker include building trust, offering in-person help, navigating healthcare systems, providing health education, and connecting with community resources. Their work improves health outcomes, reduces disparities, saves money and resources, and improves health and well-being. Many of the EHE components mirror what was successful during the COVID-19 pandemic and remain important for achieving HIV health equity, such as expanding the use of telehealth, particularly in rural areas, utilizing rapid diagnostic testing and mail order testing, delivering medications and other therapeutics, housing, food, and monetary assistance, and developing community-tailored interventions. In closing, achieving HIV health equity remains vitally important towards our global goal of ending the HIV epidemic. It will entail policies that allocate resources where they are needed the most and address many of the root causes of HIV inequities, such as poverty, lack of access to healthcare, limited opportunities for quality education and employment, stigma, homophobia, and systemic racism. Thank you for joining today's presentation, and I would like to turn it over to our moderator, Dr. Ann-Margaret Navarra, who will introduce our next speaker.
Thank you so much, Dr. Garcia. So at this time, wonderful presentation and really informative. So at this time, we're going to turn the floor over to Dr. Michael Rosenberg. Dr. Rosenberg, are you ready? And we're going to ask you to unmute as well.
Thank you. Let's see. This is the one here. Here we go.
Hey, great.
Is everything working here? I
Yep.
guess. Okay, perfect. Well, great. Good evening, everyone. It's a pleasure to be here, and thank you all for joining our presentations on this eve of World AIDS Day. We were just speaking before the conference started about how many years we've been observing World AIDS Day. When I came to New York in 1991, so it's been, well over 30 years of observing World AIDS Day. So it's humbling, and but I continue to try to look at the glass as half full as opposed to half empty. I think that's going forward, and just trying to keep moving on and pushing on and trying to end this epidemic. So without further ado, I'm going to speak a little bit. My presentation will be different than David's. And David, thank you for that lovely talk about what's going on now and in the future. I'm going to maybe take a little walk backwards, go to the past, because I think the past helps us understand the present and the future in terms of guiding us, our programs, our thoughts, in terms of how to end the epidemic. So there's be some historical stuff, and I'm going to give you stuff about treatment. It'll be a little more technical. I apologize if some of the slides are a little crowded and confusing, but if there's time for questions at the end, I can try to answer them to the best of my abilities. So without further ado, I'll move ahead. Let's see. Now, I guess advancing, I just, there we go. Okay. I'm technically challenged as well. So here's my overview. As they say, there'll be kind of in the context of historical background and speak a little bit about HIV itself, how it causes disease, because that actually helps us understand how our treatments work. I'll speak about treatment eras and the progress that they have wrought, and some of the principles of effective antiretroviral therapy, and also try to bring it into the global context. This is the World AIDS Day, not just US, but everywhere, of course, and realizing that much of the epidemic actually exists outside our borders as opposed to inside, even though obviously it's a huge thing here. I'll speak about some of the new and investigational agents that are on the horizon. I'll speak about a little bit about cure and then some reflection at the end. I won't be speaking, I know David covered a little bit about where PrEP is in terms of reaching populations who would benefit from PrEP. I'm not going to be covering PrEP or PEP, post-exposure prophylaxis, much here. It's going to be mainly concentrating on therapy for those with living with HIV. Okay, next slide. Okay, here we are in the past. So this is, I just want to point this out. So this is back in 1981, when the CDC, the MMWR, came out with this publication. They were perplexed. There were a lot of gay men, Haitians, of course, and you can start seeing where a stigma might be reaching its way in. I mean, this is the beginning, but you can see where this might be going. And then transfusion-associated immunodeficiency, and this is, of course, starting around 1981. There's a doctor in Los Angeles named Michael Gottlieb who met a young man who was perfectly healthy, but he came in with pneumocystis pneumonia, and it was unclear what was going on with him. And of course, it started being reported in major urban centers, both in Los Angeles, New York City, Chicago, etc. So coming in with these very unusual infections and cancers that you usually would not see in this age group. Next slide here. And then, of course, lo and behold, the first kind of descriptions or reports of children acquiring HIV, presumably from their mom during the birth process. Again, unexplained immunodeficiency and opportunistic infections in infants in New York, New Jersey, and California. So it's starting to kind of grow and be further recognized as that some immunodeficiency is going on that seems to be contagious or infectious. And then in 1983, the retrovirus HIV was discovered. This is a person who left their electron microscope. This occurred in France. And those two investigators won the Nobel Prize for the discovery of HIV, but they actually left the microscope for a while, and they came back and they saw these viruses budding from T cells. This is electron microscopy, a photograph. And lo and behold, they actually identified this virus as a human, as a retrovirus, as it's called. And this was the first this was an aha moment here. And what they found, of course, is that if you take HIV and you incubate it with some T cells in a tissue culture, in a plate, it kills them. It kills them terribly. It just wipes them out. And this was the basic principle of how HIV does its damage, is that it attacks T cells and it kills them, and it destroys the person's immune system over time. So that was obviously an incredible, again, another important scientific breakthrough in understanding what's going on in the person when they're infected by this virus. And then, of course, then we started seeing all the horrible and tragic effects of HIV infection in people. These are some photos taken. This was David Kirby, who died in 1990. There was several photographs done in Life magazine that actually heightened people's awareness of HIV/AIDS. It's a very moving photograph. And of course, in Africa, of course, people wasting with HIV, very called slim disease. So that here was the kind of the manifestations of HIV infection in people in terms of their loss of weight, infections, etc., opportunistic infections, and sadly, most, of course, in death. And of course, those pictures, that people who are, started to become marginalized, stigma, fear, ignorance, and stigma spread. There's no therapy available, so everyone is just panic struck that there's a contagion there, and I might get it, and I'm afraid of these people. And I have some newspaper articles here. Everyone knows about Ryan White because we now have Ryan White funding from the federal government. He was a child with hemophilia, got a transfusion, acquired AIDS, and of course he was not allowed to go to his school. His house was burned down. Horrible things happened to his family. This is an interesting. This was a doctor working with AIDS patients in Greenwich Village, and he was kicked out of his building because the other tenants in the building did not want to have anyone, even with someone who was taking care of AIDS patients. So this is just two stories of many, many thousands, hundreds of thousands of stories of the stigma and the horrible kind of marginalization of AIDS patients, HIV infected persons. And of course, as I said about, obviously there's no therapy. So this was a relentless disease. It didn't obviously kill people over time. It took oftentimes, several years before people died. But you can see that HIV ended up being the top cause of death rates in young people, 25 to 44 years by 1994. It's kind of peaking there. Overcoming unintentional injuries, cancer, heart disease, suicide, homicide, liver disease, stroke, and diabetes. So the number one killer in this age group, young age group, who usually are not, as they say, are maybe dying of some of these, but generally maybe have unintentional injuries or so on, homicide and suicide. But from medical diseases, this was just shocking. And it's just, you can just see it's almost exponential, the line going up. Similarly, in children born with HIV, vertically transmitted or perinatally acquired HIV, you can see this is the cases of AIDS cases reported. And this was, you can see age less than 13 years and age greater than 13 years. You can see here, there was a peak right around 1992 or so. So also, obviously, children born to infected with HIV also were experiencing disease and death as well, and immunodeficiency from their infection. So a very bleak picture at this point without any therapy. And this is the global, as again, keeping also obviously being mindful that it was happening on our shores, but also everywhere else, knows no boundaries. You can see here the peak right around 2004 or 5 was a peak, really global peak. This is 2 million deaths per year. This is his number of deaths per thousands. So, and you can see the Africa, these two lines here really represented Africa, sub-Saharan Africa in particular, as the biggest burden. So a lot of mortality due to this virus. This is a nice picture. I went to South Africa in 2003 and did some work in an HIV clinic, and saw a beautiful culture, beautiful and resilient people. Just an amazing trip. And so going back to, again, historically, so March 1987, a drug was born, zidovudine, AZT. Everyone's probably heard of some iteration of that. It was developed in the National Cancer Institute. It was actually an anti-cancer drug that had been developed before, but it seemed to work against HIV. And there was a first patient treated in 1983 with an IV formulation, and his T cell counts, I think he was a he, you have to excuse me, I don't remember. There was a reversal he actually reacted to he was immunosuppressed, but he reacted to a tuberculosis test, and he felt better. And there were some other trials that were then done after that. And one of the important things about this was that it established kind of the format for clinical trials going forward, because, you know, there wasn't really a roadmap for how, if we have drugs, how do we test them? How do we evaluate them? And then how do we get the drug out to the people? And that used to be a slow process. And because it was so slow, I'll show you in a little bit, it led to lots of consternation amongst people living with HIV and their loved ones. So there was some promise there initially, because there was a controlled trial in 1987, and there were 19 deaths were people who received a placebo and one on AZT. So that way everyone was saying, oh, maybe we have that, we got it here. And the T cell counts went up as you might expect, but there was a lot of toxicity from the people getting AZT, really severe anemia. Sometimes the patients got really sick taking the drug. One wonders whether they were sicker taking the drug than being off the drug at some point. But alas, the virus, this is a smart virus. I don't like to anthropomorphize, but I do frequently, because the thing is, it seems to be a genius. Wherever we throw at it, it seems to try to escape. So it turned out the virus became resistant to this drug. So those benefits that those patients experienced were short-lived. And unfortunately, in the communities who were getting AZT, and certainly research participants, from the outside, if you're from the outside looking in, you might think that the ZDV, they had a lot of side effects, that this zidovudine was maybe more like, was more hurting them than helping them. And AZT developed actually, certainly in the communities, oftentimes people said that this drug was, killed people. It's one of the things that was, it was not in hindsight now, we realize that a single drug is not going to help, but it was difficult times. Hopeful about AZT, but it really didn't pan out. And then, of course, organizations started to grow in terms of ACT UP specifically, which were very instrumental in forcing officials to recognize HIV as a problem, the federal government, and then to force the arm of the research establishment to get these drugs into tests, evaluation, and into the communities where they were needed to accelerate the process of drug development and dissemination. Here's a pipe. So here's an ARV timeline. So here's the first one was approved in 1987. And there was these nucleoside analogs, didanosine, stavudine, some of these drugs we don't use anymore. They're X'd out. So in between 87 and kind of 96, there just wasn't really much movement. They combined these drugs together sometimes, but there was a lot of toxicity, and the patients really didn't benefit for very long. There was some temporary benefit, but not very much. And you can see, I'm going to go into this later. You can see it gets much more crowded there as we get towards the, to the middle of 2000s. And then in 1996 at the Vancouver AIDS Conference, David Ho, who used to be at NYU at the Aaron Diamond AIDS Research Institute, he's a brilliant investigator. He presented, he's actually in his lab, they kind of figured out what's going on at the cellular level. How is the virus replicating and how is it causing its damage? And they also presented at this conference was that the fact that if you actually combine 3 drugs, and we had a new, right by 96, we had a new, more potent drug called a protease inhibitor. If you gave those 3 drugs in combination, you could shut down the virus and reverse the disease process. So highly active antiretroviral therapy, what we know is HAART. Most people know this, have heard this term bandied about. We use it pretty regularly now. This is when HAART was essentially kind of born, I would say. So this was a huge, this conference was kind of like a sea change in terms of how we approached HIV treatment. And the basics here again, the kinetics of viral replication. So in an untreated person, one has to realize that actually they're making about 10 billion new viral particles per day. It's an unconscionable, some making more, some making less, but on average, a tremendous number of viruses. Now, this virus, HIV, it's a retrovirus, I said, it has a sloppy enzyme that when it copies itself, it's a sloppy enzyme. It makes mistakes. But when it makes mistakes, it actually makes viruses that are different from each other, which then can hide from your immune system and so on. So it's very clever in that regard. And then the other thing that happens is that the HIV virus actually integrates into the cells, T cells and other cells, and forms a reservoir, and including in the central nervous system, in the male urogenital tract, and so on, and other tissues. And that serves as I say, a reservoir that may be very difficult to get out, to eradicate from the body forever. Of course, as we said, it causes this unrelenting destruction of T cells. And with our current therapies, even to this day, we don't know, we can't get rid of that kind of latently, that virus that's laying dormant or silent in people living with HIV. This is the problem in terms of cure, and I'll get to that later on. They're basically invisible. These cells are invisible to the immune system. So we're left with we can treat this infection and we can get it under control, but we cannot eradicate. It's still a chronic infection that we have not found a cure for. And this is again another graphic this was the paper where they actually described what's happening with the virus and the T cells. So if you knock out virus replication here, you're going to have cells that are happy, they don't get infected. Okay. If you don't, obviously you have HIV infected cells. Some of those cells become latently infected and dormant and serve as a reservoir. So the way to try to shut this down is try to get good therapy so you can actually preserve these T cells. That's the goal of treatment. Protect those T cells from getting infected. And trying to actually stop this from happening too, because if you can make this as small as possible, maybe you could achieve a cure if there's less of that hidden reservoir in the body. And as opposed to, so here's a natural course of events with HIV. Of course, before treatment, you have infection, you have a viral load, it goes up, and then people kind of reach what's called a set point. And here's the T cells, they go down transiently, but then they go up, but then the latency period used to be about over 10 years or so. And you can think of, and this is the train here, and the train speed is the viral load in the blood. So in other words, the train will go faster if the viral load is higher because it's going to kill more T cells. And you're going to get down to these areas where you start developing opportunistic infections, PCP, thrush, toxoplasmosis, all these various things that can be potentially deadly. So instead of that, this picture, with heart, you can see actually, there it is, sorry. With heart, you can see that actually, once the viral load, when you apply therapy, you can get that viral load down to what's called the limit of detection or undetectable levels. And your T cells are happy, you protect your T cells. And hopefully this scenario will lead to obviously a much healthier life, longer life, free of opportunistic infections, and so on and so forth. Okay. And that's exactly what happened. So when protease inhibitors, I told you that was a new drug that kind of changed the game. You can see here, look at the number of deaths actually started once the use of PIs, which is right around 1995 to 6. You can see the deaths kind of inversely mirrored the rise in the use of PIs. So it definitely had a profound effect on people's lives, this combination therapy. It was like the Lazarus effect. People actually, who were on death's doorstep, kind of woke up and could resume their lives again to some degree. And this also occurred, I've been talking about mainly adults, much of that data is adults, but this also occurred in children. It's a little later because, access to and formulations for these drugs actually take much longer sometimes in pediatrics than adults. But again, introduction of heart, this is AIDS and death here, hospital admissions, And the mortality rate was about 20-fold when you had no or monotherapy, mono or dual therapy, and then highly active antiretroviral therapy. You can see there was a considerable drop in mortality in children with HIV. So it worked for children, it worked for adults. Pretty much if you could stop the virus from replicating, you would have generally success. And this is mother to child transmission over time. So here was this is when we used AZT here in 1994. AZT became available for mothers. Pre-AZT was about a 25% transmission rate. This is in the US. And then over time, with the application of HAART given to pregnant women, the transmission rate, and now this is 2002, and I can tell you that the transmission rate now is on the order of a 3 or 4/10%, if not less, in the US. It's almost dropped to, there's maybe 20 or something odd HIV infected babies now born in the country as of 2021. So a remarkable effect on vertical transmission or perinatal transmission. And these are the studies that were conducted throughout the years to establish these facts. This is from this, there's lots of interesting, cool, billboards in South Africa. This is one just tested, getting married, and see them all over the place. They're great. This is also, I think, also very relevant for us living in New York. This is actually the perinatal HIV among children in New York City, 1998 to 2020. The red is infected children, indeterminate. Most of these probably will end up being either non or infected. But here you can see here over the last, look at this, this is numbers. So this is since 2002, 1301111. This is still indeterminate because COVID-19, as David had spoke to, kind of interrupted many attempts to help people with HIV. So it's had a profound effect, obviously, of mothers obviously taking highly active antiretroviral therapy in terms of preventing transmission. Viral suppression, but I have this, but at what cost? Because the thing is, the drugs we had then, I have to tell you, were pretty, I would say, what's the right word? Just a bit overwhelming. I mean, just looking at them as clinicians and prescribing these for patients, you would take pause because they were very, very complex, very somewhat intolerable, oftentimes many, because they had the size, the shape, the number of pills. For children, horrible, the liquids were horrible tasting, very vile on the tongue, on the throat. It would cause burning, they would vomit, especially the protease inhibitors, which we all tried as pediatricians, giving these to our patients. We actually tried them and we realized that these were just the most horrible tasting stuff. Yeah. And you don't know how any child could ever really take this. Food restrictions too. You have to take some with food, some without food, scheduling 2 times or 3 times a day. Toxicities as well. So there's short-term and long-term, organ, liver, kidneys, bone and blood, lipodystrophy and drug-drug interactions. And let's see, I think the next picture I have. So here we have some of the pills. These are the pills. This is a protease inhibitor. I think this is ritonavir, if I'm not mistaken. Varicept, these gel caps and so on. And they're large, they're just tough. And here is a patient we took care of who has terrible, what's called lipodystrophy, which is fat, accumulations of fat or loss of fat in patients taking these drugs. And you can see this huge kind of a collection of fat on the back of her, on the upper part of her back and on the rest of her body. And here's a gentleman who actually has loss of fat in the face. It's called facial lipoatrophy. So there are a lot of side effects, and many of them are stigmatizing that would actually identify people as maybe HIV positive because they're taking these medicines. It in many cases, in some of the children we took care of, not as much anymore because we have better treatment, we had to put gastrostomy tubes in them to give them the medicines because they couldn't take them by mouth. They would just refuse. They'd run away. Very, very difficult. And you can imagine how difficult it was for parents. And now we have, so I'm going to jump a little bit. So we have this antiretroviral drug pipe timeline. And you can see here, there's been just a flurry of activity. Obviously, it's just gotten more dense as you go towards the the 2018, 2020. These are major kind of developments. In particular, the development of integrase inhibitors has really changed the landscape. That's a class of drug, which I'll get to later on. That is really, in terms of providing treatments that are easy, tolerable, and durable, it's really been a game changer, I would say, in terms of treatment. Let's see. And here's ART 2022, easier, less toxic, more potent, multiple single tablet regimens approved by the FDA. So here's I think it's a Biktarvy pill. I don't work for any of the drug companies, so this is just an example. And this is, this is Camavir and I think and Kaletra here, or Retrovir. And, you can see the stark difference in his hands, in his palms. So the present. So here's the principles of antiretroviral therapy. Maybe I've kind of alluded to them already, but the goal is to treat early and hard, using multiple drugs to suppress viral replication to as low as possible, an undetectable viral load. That's our mantra, undetectable equals untransmittable, U equals U. If you can do this, it's gonna provide incredible benefit and health to the patient. And not only that, it's treatment as prevention, because you'll prevent transmission to their sexual partners, to their children, if they're IV drug users, even amongst IV drug users, it can prevent transmission to their fellow IV drug users. So this is the goal. Preserve and restore immune function. Obviously, that's the benefit of that. If you get the viral load down, the T cells go up in general. You want to prevent drug resistance, because the thing is, that's one of the other big problems that has happened is when we didn't have such potent regimens, patients would take the medicines, and if they actually didn't take them that well, they would develop resistance to those drugs, and then you'd have to fashion a new regimen for them. And then if they're having the same problems, they'll develop more and more resistance. And the problem with resistance, it's a library. Every patient who's ever developed resistance, they have that resistance sitting in their cells, and you can't really go back to those drugs anymore. That's a difficulty of HIV again. That has complicated, obviously, finding treatments for them. You also want to decrease the incidence and severity of comorbidities, because HIV also leads to chronic inflammation in the body. And chronic inflammation causes some of the end organ damage, like cardiovascular disease, kidney disease, liver disease, and so on. So if you knock down the virus, you can also knock down the degree of inflammation that's going on. You improve and enhance the quality of life. I mean, that's the goal there, because you want everyone to live a happy and healthy life and not have to worry about all this other stuff. I call it the KISSES strategy. Keep it simple, safe, effective, and sustainable. This is the HIV life cycle, because I wanted to talk. I've been talking about the drugs, and I know this picture looks a little, it's a little busy, but just focus your eye. So HIV has to get into a T cell, so it has to attach and fuse with the membrane. So there actually are medicines that act on attachment. They're called attachment inhibitors or post-attachment inhibitors. There's also a fusion inhibitor called Fusion, which actually prevents it from fusing with the target cell. Now, once it gets in, it releases the RNA. It's an RNA virus, and that RNA virus is actually copied into a DNA copy, And that's called reverse transcription. And there we have lots of drugs. Like AZT, for example, was a drug that acted on this step. And then this double-stranded, this viral DNA actually, now here's the thing, it goes into the nucleus and it actually inserts into the host genome. So this is when I talk about latency. So this virus gets into, and it's in your gene, it's part of your genome now. And how do you get rid of this? Well, this is hard sometimes because, as I say, these infected cells sometimes may be sitting quietly in the host for the lifetime of the host. And that's where the eradication, because sometimes these dormant viruses will become active again and start making HIV. Once they're in there, this is, as they say, they make new copies of themselves. They assemble, there's all sorts of cleavages going on. It's very, very, it's a little factory of viruses. The virus components assemble, and protease inhibitors work here in terms of the assembly and the budding of the virus. And there's also called maturation inhibitors. And then a new virus is released here. So we attack, so typically the theory about treating HIV is that you attack various parts of the life cycle of the virus. And in particular, the integrase inhibitors have turned out to be one of the most potent drugs that we have. And they've really kind of like taken over in terms of our treatment, the drugs we oftentimes use as a first-line agents and even further on. Okay. Here's an available, I won't dwell on this, but this is all the names of the drugs. We have integrase inhibitors, reverse transcriptase inhibitors, boosted protease inhibitor regimens. So these are all the available first line, and the importance of the beauty of these drugs is that they're combined in a single pill, 3 to 4 drugs in one pill. So no more having to take 10, 12 pills. They're all combined and they're small and they tend to be tolerable. And many of them don't have food restrictions and so on. So it's gotten so much easier than previous times. And we have guidelines. So the thing is like, well, you have a lot of drugs, but how do you use them? Because there's experts that do this all the time. So guidelines have risen ever since 1996, have been published, obviously year after year, and are updated continually, which guide clinicians in terms of like the best science in terms of clinical trials and so on, to guide them in terms of treating. So we have guidelines so people aren't treating willy-nilly with whatever kind of combination they want. They have guidelines to help to kind of standardize their treatments. And this is the most updated guidelines for first-line antiretroviral therapy in people with HIV. And if you notice, there's oftentimes different organizations. The European organizations have their own system. Generally, they all come to the same conclusion. But all the drugs now are pretty much single tablet regimens that have 3 to 4 drugs in them typically. And it has an integrase inhibitor and tenofovir, which is a drug and this part here, which is oftentimes used in PrEP, just this part of it. It's called TAF and FTC, or TDF and FTC. These are 2 nucleoside analogs that act on the reverse transcriptase enzyme. So it's gotten these are first-line regimens. So these are single tablets, oftentimes very well tolerated. You can see, and they're pretty much these mirror these different organizations. Pretty much have the same recommendations. What about pregnancy? We deal, obviously we're at the other end when the babies are born, but how best to treat pregnant women safely and effectively so there isn't any transmission to their children. And again, pretty much dolutegravir, which is an integrase inhibitor, forms the backbone of most of the potent regimens that we're using now. Or you can use a protease inhibitor. Again, this might depend. Every case is different, and the clinician may choose one or the other based upon the patient's characteristics. But nonetheless, it has gotten so much simpler overall than before, and potent, as you can see. These are other drugs that are actually one thing to know is that pregnant women, they're obviously their metabolism, everything changes in a pregnant woman. So how the drugs are metabolized and eliminated in the body are very different than a non-pregnant woman or a man or a child for that matter. So we're collecting data on this. And so very important, there's an antiretroviral pregnancy registry where women are enrolled, because the thing is we want to know how they did and what their outcomes are. But this sometimes comes slowly because sometimes clinicians are not willing to choose a drug that may be iffy in terms of its potency and so on. PK concerns, pharmacokinetic concerns, and other, we don't know if it's going to achieve the right levels in a pregnant woman as it would in a non-pregnant person. But those studies are going on as we speak. There are many studies that are actually trying to address it, including here at Jacobi. We have a couple women involved in studies getting these drugs and looking at the levels in their bloodstream while they're pregnant. And as you can see, dolutegravir-based, let me get rid of this, ART seems to be superior to efavirenz is a drug, a tripla, that we use that came about in the late 90s, actually, which is a very effective drug, and some people are still taking it. But it's clear that, and women are taking it as well, pregnant women, but it's clear that dolutegravir seems to be much more effective. This is actually women in Africa, this is in Africa, who are starting anti-ART, let me just say, late in pregnancy. This is about the median time when they delivered, which is about 55 days after they started. And you can see there was a really separation between the dolutegravir group and the efavirenz group. So these women, this is people becoming undetectable, less than 50 copies. So there was a huge difference. And so looking at dolutegravir, same thing over here. This is women starting dolutegravir in 14 to 28 weeks of pregnancy. Again, a dolutegravir-based regimen, an integrase inhibitor, was superior to efavirenz in pretty much all aspects. So very, very encouraging results in these clinical trials. And however, always, as they say, look at the glass half full, but you always have to be careful because, you never know what curveball you might get. So there was, in 2017, there were reports from a prospective Botswana study. This is that cited a 0.9% prevalence of neural tube defects in babies born to mothers who conceived while receiving dolutegravir. So this was like, oh dear. And this prevalence was obviously higher than the background. So everyone took pause and the trials were held for a little while, but it looks like that was an aberration. May have been, it's not clear exactly what happened, but it looks like the data seems to show that neural tube obviously by a couple of years later, neural tube defect prevalence no longer significantly higher with dolutegravir than with other antiretroviral therapy. So we all brushed our brows, and hopefully this is past this because, obviously again, safety, that's the do no harm is the goal here. So the thing is, you may prevent HIV transmission, but then you have a baby with a congenital anomaly. And so you want, as they say, safety is of utmost. That's the first thing that in any clinical trial you have to establish before you looking at efficacy or anything like that. But that was a huge sigh of relief. U equals U for mothers on ART, and this is a study from France, and it showed among about 6,000 women who are on antiretroviral and ART, at conception. There were no perinatal transmission was observed among over 5,000 infants born to women treated at conception and having an undetectable viral load near delivery. You can see here, undetectable viral load, less than 50, 0, lower limit of quantification. If they didn't have, sometimes it's less than 200, even less than 1,000, 0, 50 to 399, well, you're starting to see a little bit, and then greater than 400, there was some transmission going on. But again, if women started medicines at conception and were undetectable near the time of delivery, pretty much no transmissions going on. This is from 1986, so it's a pretty robust data set. Attesting to, again, if you knock the virus down, you'll generally have success most of the time. Here's some cute kids hanging out and enjoying a photograph from a visitor. And improvements, there's been improvements obviously in children. Again, I've been kind of going back, I'm a pediatrician, so this oftentimes obviously interests me and compels me, is that it's also gotten much more simple in children in terms of also formulations. We have granules now, we have things that dissolve. They're much better tasting. They're not as cumbersome, and they're potent. So we're not obviously there yet. We still have lopinavir. This is Kalitris, so we still are using PI-based regimens in some cases, but it certainly has gotten easier than it did before, and more tolerable. I mean, tolerability in a pediatric patient is tantamount, because if they taste bad and things like that, they're going to spit it out, and they know, and then you're back to square one. So, okay, now I'm going to move on quickly to the advent of injectable ART, because people have been hearing a lot about this. Maybe people see ads on television I see them. I mean, what I think has been striking even is that through the last couple of years, you see ads for Biktarvy and this drug called Cabenuva, a lot. I see it, I guess it depends on what channel you watch, but maybe 4 or 5 times during the program that you're watching, you might see these ads, which I think is great, because if it's anything to reduce stigma. Why injectables? So HIV is a chronic, obviously, infection that requires lifelong daily oral treatment, at least for now. Biomedical HIV prevention, in terms of for example, PrEP, requires oftentimes daily or frequent oral medications in otherwise healthy people. So people taking PrEP, taking Truvada or Descovy daily. And despite the success of daily oral ART, challenges exist. So we have adherence problems, even with one pill burden, stigma, like you have to take a pill somewhere. Maybe you can't take a pill around a certain group of people because you don't want them to know your status. So that has led to the development of injectables. And we have this Cabenuva, which is this first complete long-acting regimen, or what we call LA. And there's been approvals already in Canada in March 2020, Europe, December 2020, United States, we're a little behind, January 2021, and Australia in February. It comes in these various formulations and packs. And lo and behold, as I said, in January 2021, it was approved for use in patients, sorry, I have to move here we go, with viral suppression and no prior resistance on an every 4-week dosing schedule in US and Canada. And it was approved for every 8 weeks or every 2 months in the European Union. And there's both an oral formulation as well as, this is the drugs, cabotegravir and rilpivirine. And in the sustained released injection material to be initiated 1 month after oral lead-in phase. Why they did this is that the thing is that when you get a new drug, if you have some allergy to it, if you inject it, it's going to be a long time before that medicine can get out of the body. They have actually since, so they had an oral lead-in phase where you take the medicines by mouth for a month. That's now become optional because they have found that so few people have allergic reactions to the injection that they have actually made this voluntary or not mandatory. And of course, this trial, which compared the 4-week to the 8-week, they had some very good success. It's a larger injection volume, 3 ml versus 2 ml. And overall, they saw very few injection site reactions, and the rates decreased over time in both groups. So this is now an injectable sorry here. Nope. A drug that's very, very potent and very, very effective at getting people undetectable. And this is what it looks like. We actually have a study here going on at Jacobi. It's obviously concluding. This is 2 mLs of the cabotegravir. It's, they get an injection in each buttock patient. This is a very thick liquid. I mean, I want to show you guys because the thing is, like, sometimes showing these trials and things like that, it's a little kind of a remove from the day-to-day stuff, but this is what it looks like. It's thick. Does it hurt going in? Yes. You can't say it's completely painless. It's not, at least from what I hear from our patients. But if you actually look at some of the trial data showed that the discontinuation, these are all the various adverse reactions you can have to, and this is with any kind of clinical trial. If it's over a certain grade, they will document it. Injection site reactions, fever, fatigue, headache, and you could see injection site reactions were fairly common, but the grade 3 or 4 were very low. These are the more serious ones. The grade 1 or 2 are ones that are more minor, that typically some redness and swelling that resolve quickly. This is both 2-month and the 1 monthly. You can again see fairly low serious side effects from the injection. And generally, if it's really bad, people will stop, right? They're going to say, I'm not taking this anymore. And the discontinuation rates were actually very low, like 2 and 3%. So that I think that attests to the fact that even though there is some acute pain, many of these patients, this is actually a cohort of people who have been not adherent to their pills. And even if it was fairly simple, but now they have to come back either once every 1 month or 2 months to get their injection. And they seem to be thriving with this method and many people, it's not for everyone, because some people have needle phobias and things like that. They may not be interested in these injections, but they are very effective and seem to certainly be effective in non-adherent patients for one reason or another. And I wanted to tell you here that typically the injection site reactions, because this is the question that we get mainly from patients, is like, well, is this going to hurt? Can I sit down? Can I walk? Am I going to have bumps on my buttocks that are going to be unsightly to my partner or anything like that? So, and generally, the most thing is pain. There are some nodules. Again, most of the time, these side effects will resolve over time. Again, as they say, 1% of patients receiving every 2 months discontinued. So it seems to be not as much of a bother as when you first see it. You're a little shaken up. You say, "Wow, that's a lot. It's going to hurt," but it seems to work really well. And I have to say, I don't have any, I don't have any stock in Cabenuva or anything like that. This is just my experience with patients in the clinic and from the clinical trials. And this is actually very interesting. I wanted to put this up. This is a first demonstration project of using a long-acting injectable ART, that is cabotegravir and rilpivirine, for persons with and without a detectable HIV viremia in an urban clinic. This is at UCSF, which has kind of been on the vanguard of these, trying to get people in, as soon as possible and treat them. High rates of substance use disorders, psychiatric illness, unstable housing. So the patient that that you're going to have difficulty finding and treating and retaining in care. They had 132 people with HIV referred, 51 started injections, follow-up reported on 35. And they had on-site, and they have obviously services they provided to try to keep these people engaged, support adherence. And 24 had baseline viral suppression, all maintained during follow-up. And you can see this, it's great. And this is a very, very difficult patient population to treat. They actually had very advanced disease, a CD4 count of 99, viral load of 50,000, some with some resistance, but they had very prompt responses and no treatment failure or resistance to date. So this is kind of a proof of principle that actually maybe, especially in these, we were talking about obviously disparities and making it equitable to all populations. This might be a treatment for those folks, this injectable treatment in terms of getting them healthy. The future. Am I doing okay with time?
Yes, just,
Okay.
we want to leave a little bit of time for questions. So
Sure.
we're at 7:12 now.
Okay. Okay, I'll try to go through these rest. Let's see.
Thank you.
Oh, you're welcome. So this is actually we have a lot of ways to deliver drugs. And so people are getting, a lot of smart people, much smarter than I, are actually, figuring out ways how you get ARVs and obviously injections, long-acting oral medications, wearable infusion pumps, microneedle drug patches, subdermal implants. We have some of the experience, obviously, with contraceptives, long-acting contraceptives, vaginal rings, but lots of different modalities that we haven't really exploited before that maybe we can now use in the realm of antiretroviral therapy. And here's a bunch of compounds that are in clinical development. You can see a whole bunch of them. Some of them I can't even pronounce, that are in clinical trials. Some, end up being dead ends, some not, and they go further into clinical development. But there's certainly still a lot of activity in this area. I was going to concentrate on a couple new drugs on the horizon: islatravir, lenacapavir, and broadly neutralizing monoclonal antibodies. They're a mouthful, I know. Let's see. So islatravir, it's a new drug. It works kind of like the reverse, like the drugs that AZT and DDI and so on, 3TC, lamivudine. But it's a new way how it works. And the beauty of this drug is that it lives a long time in patients' bodies, so it has a long half-life. And any drug that has a long half-life means you have to give it less frequently because it's sticking around longer. It's getting eliminated over a longer period of time. And you can see the half-life inside cells is 128 hours. So it's a huge time that it's in cells and acting. It's being evaluated for prevention. So in terms of PrEP and treatment in pill, implant, and IV formulation. And it's, in terms of the pill, it's actually given once a week. So that's going away from, as I say, our daily medications that we have now. And this just shows how potent it is. This is a single, like a 0.5 milligram. Is in a matter of days, it drops the viral load to undetectable levels. This is a dose finding study. So this is just a very short, just showing that how potent these drugs are. One dose given over this time, and the viral load goes down to undetectable levels. So that's pretty amazing. However, so I again, like I mentioned with dolutegravir, let's say, and the neural tube defects, well, they had to, sadly, this drug was put on what's called a clinical hold, because what happens is that they found that patients in clinical trials, their T cells were dropping more quickly than you expect your T cells to go up when you suppress virus. In this case, it was going down. So there seems to be some unclear toxicity to T cells. So this drug is now, sadly, there were many offshoots of this drug in terms of combining it with other drugs. It would have been a real, really kind of a slam dunk, so to speak. But alas, and this is I showed this because this is the up and downs of clinical trials, and how we actually appreciate when patients enroll in these clinical trials, because the thing is, sometimes bad things can happen. And that's one of the things that they are willing to accept for the potential benefit to them and others. So, but sometimes it doesn't go the right way. There's another drug called lenacapavir, which is an HIV capsid inhibitor. So this is an interesting drug. So as I told you, when HIV kind of infects a cell, the DNA, the genome is wrapped up in this little, looks like a basket. And this capsid inhibitor actually plays with this basket. It doesn't allow it to migrate around the cell, and it doesn't allow it to uncoat. So it basically disables the whole replicative process. It's a very potent drug. So this basically shuts down, again, the virus again. And this is a completely new class of drug, which means that there's no HIV around that presumably should be resistant to it, because it's a totally new agent. And that's exciting. And so it's very potent. It retains full activity against all these resistant viruses. And this was actually developed, some of the drugs I'm talking about was developed for people. I spoke about the new regimens that are so easy. But oftentimes those regimens are being tested in patients who've never been treated. They're naive to treatment. Patients like certainly perinatally infected individuals, young men and women, oftentimes have a lot of drug resistance. And therefore, these agents are going to be maybe helpful for them in terms of controlling their virus going forward. And there's an oral and subcutaneous injectable formulation. There's trials going on in people who are naive, that is, never received medicine, newly infected. And then these multiply drug-resistant patients who have an HIV that has a lot of resistance, called Capella. And so far, it's quite potent as well. This is actually just showing that an injection dropped the viral load to undetectable levels, pretty much placebo, nothing. And the decrease in viral load of greater than 0.5 logs, again, which is appreciable, was super high, obviously 88% and 70% in the placebo group. So, and the here's the kicker. And so this is injected every 6 months. Okay, we were talking about every 1 to 2 months with Cabenuva. Now we have once every 6 months with this drug. So it sits in the body a long time. They get 2 injections, usually typically in the stomach on each side of the belly, subcutaneously. You have to take it though with other ARVs. That's one of the, at least right now, it's called an optimized background therapy, whatever other drugs that you could take that are effective. That may change. And the other thing is that, again, is that resistance can occur. And in the trials, resistance occurred in patients who were actually, they weren't adherent to their optimized background, their oral therapy. They developed resistance to those drugs, not to this drug. So adherence matters. It still matters even with these very potent drugs. It still makes a difference. And it's something that we have to be cognizant of. And obviously, let's see. And there's another hiccup with lenacapavir. It seems to be like and this happened to us because we have some patients in this trial, and clinical trials resumed May 22nd, but they were stopped because there was some interaction between the glass cylinder that contained the drug, and they had to stop it for a little while. They fixed it. It's back up and running again. And I think we're over the hump there. But you can see that, in these clinical trials, there's obviously sometimes a little wrench is thrown into the works, but it comes with the territory, I guess. And then the last thing is broadly neutralizing, antibodies against HIV. So this is the spike. This is the protein that sits on the top of the HIV. And the way you can stop it from attaching to T cells and killing T cells, if you actually make antibodies that glom up on this GP120, it's called, and stop it. It's basically covering it up, and it can't attach to the cell anymore. And there's a whole bunch of new, what's called monoclonal antibodies that have been developed that are very, very potent. They can also act across HIV from all sorts of different areas all around the globe, because HIV differs from place to place. The African HIV differs a lot from North American HIV in terms of what's called a clade. So these are on the horizon. They're they're typically given IV or subcutaneously because they're an antibody. You can't eat them because they'll get destroyed in your stomach. But this is another promising area of investigation, and there are trials going on. And there's actually now antibodies that they actually have 3 arms. Antibodies typically have 2 arms and they're the same arm, but this has 3 arms and they're 3 different arms. So because what they found is that if you just gave her 1 antibody, you would have the virus again is clever and you would develop resistant virus. Now, if you give something 2 antibodies, same thing would happen. But if you have a tri-specific one, you don't have any resistant virus. So those are being engineered. They're already resistant and they're being tested as well. This was in an HIV infected monkey, where they do some of these experiments. Here's a nice, beautiful bird of paradise. And the cure I won't spend long on this, but basically, do you remember I told you about the latently infected T cell reservoir? Again, this is the cell that actually where the HIV is kind of hiding, and how to get to it and how to eradicate it. This has been the crux of these investigations, and we're still not there yet. You may have heard, may have heard, there have been some patients. This is Timothy Brown. He identified himself. He died recently. London patients. All these patients have gotten very sophisticated treatments because they had cancers, blood cell cancers, and they got bone marrow transplants. And that seemed to, the right bone marrow transplant with the right treatment led to them actually being that you couldn't find HIV. You can find HIV. This patient's still alive. He died. They could not find HIV anywhere, doing all sorts of biopsies and so on. So there is proof of principle that you can cure someone. However, is that scalable? You can't do bone marrow transplants for all of sub-Saharan Africa and wherever else people live with HIV. So that's the problem that we're facing, or the challenge, I should say, that they're facing. There are a lot of smart people working on this. These are the various things they're doing, like gene and cell-based therapy, shock and kill, block and lock. They have all sorts of funny names here. Early antiretroviral therapy, trying to find people really early, and immunotherapy, using the immune system. So that goes on. And then I have a little reflection. I'm almost done. The PASS's program, I wanted to show the AIDS quilt here, which was conceived in 1987. This is obviously a picture. It almost, it's a little, you don't see the individual quilts, and I apologize for that, but I just wanted to show just the enormity of this quilt. As of now, I think there's about 110,000 names included in the quilt, but representing, over 700,000 deaths in the US since the AIDS epidemic began. And sobering, I think, but beautiful as well. And as David alluded to, I think before, as I say, the peak of deaths kind of around 2004, this is globally. Again, this is kind of like, in other words, what is the work we have to do in terms of getting therapy to people living with HIV? And still a lot of deaths here, 680,000 deaths. So we have to so obviously many of these people may not have access to antiretroviral therapy. And, you could get this, the goal would be to get this to zero. And this is the treatment cascade that everyone's maybe familiar with in terms of people living who know their status. And this was the 90-90 targets that were set for 2020. And there are gaps. I mean, they've made amazing progress. 81% here, 67% here are people who are living with HIV who are on treatment. Okay. And there is a gap, obviously, here from here to here. And then people who are living with HIV who are virally suppressed, 59%. So we have work to do, definitely. We've made a lot of progress. And this is in the US. This is the care continuum in the US. And only about 50%, 57, and I think David alluded to that as well, about are virally suppressed in the US at this time. This is from 2019. This is our latest data. So that's a little bit alarming. Because remember, most of the people who obviously acquire HIV infection are people who don't know their diagnosis, of course. So there's people here, but this is this again alludes to the fact that outreach, capturing these patients, engaging them is, and then of course, suppression, they could start medicines, but if they aren't taking them, they won't be suppressed. So the adherence issue, of course, is tantamount. I found this somewhat sobering. This is actually this is for youth attending 13 urban centers in the United States. And they actually had, pretty similar along here in terms of adults engaging here. But if you look at the number of virally suppressed, these were actually relatively newly diagnosed. So this may not reflect, obviously, the country as a whole in terms of youth. But it's again, 12% is low. So something to food for thought, certainly. And let's see. So here we are. We're in a cave, but there is light. They're going to find their way. These two fellows here. And I want to acknowledge all the people I've worked with, Jacoby, Elaine Abrams at the Columbia, of course, Ann-Margaret and the NYU Access team, our funders, and of course, first and foremost, all the patients and families for their determination, courage, strength, trust in us, willingness to participate in research studies, various educational organizations, foster care families, community organizations, volunteers, and anonymous heroes, whoever they may be. And I think this is some people volunteering to paint about creating a generation free of HIV. That would be a wonderful thing. So thank you for your attention, and love to entertain questions. And yeah, thank you all. I'm sorry if I went over. I probably went over a little bit there, so my apologies.
Thank you so much, Dr. Rosenberg. That was fabulous. And I felt that I had a 30-year walk through my career dating back to 1992. And thank you so much, Dr. Garcia, for your presentation as well. So at this point, without further ado, I'd like to open the floor up to any questions, because there's been so much rich evidence and data that's been presented. We could go with the showing of hands, or you could enter the question in the chat. Tony, are you trying to unmute? I thought there was somebody trying to unmute. Well, you know what? I'm going to ask a question, if all of you don't mind staying on. When thinking about this latent reservoir virus that really is the golden goose that we're all trying to, get at, what do you think the future holds as far as treatment? We have long-acting treatments that are administered once a month or biannually, but what do we do about the reservoir virus that will remain at this point unless there are therapies or a therapy that's been discovered that could get to this reservoir?
Yeah, I think
especially when we think of cure.
Right. I think, well, probably if looking at it from I guess several angles. So one of the things is that if you, like I mentioned about early initiation of antiretroviral therapy. So matter of fact, there have been some studies where people have gone off treatment after, if they started super early, which in other means they didn't have time to establish a latent reservoir. So with our current therapies, we could do that, but however, it would require immense effort in identifying people who are newly infected. So that's upfront. So that's one way where therapy might actually, it's just starting early therapy may itself bring about a cure. I mean, they have had these they're very tantalizing patients where they've actually been able to stop their therapy and they're actually remain undetectable when they started really early. But it's not universal, certainly. So that's one area. What I actually tell, oftentimes because patients ask about cure and things like that, and generally, as I say, the current treatments that they have will not cure the virus. But what I usually tell patients is that, if they're doing well, they're suppressed, is that to keep taking their virus, because clearly I think to be eligible probably for a cure, you probably are going to have to be virally suppressed, because if your virus actually, if you stop taking your medicines, you see that latent reservoir again. In other words, you can replenish it. Let's say every time your virus load goes up again, and then you can see that's kind of like a mark against you. You know what I mean? So it makes it more. So you're like in a vicious cycle. So I guess in terms of preparing people for an eventual cure, the goal would be to promote adherence and keeping your viral load down all the time. Never kind of letting go, and that of course requires a certain a degree of vigilance. But I think I use it as a I use it maybe as a kind of as a tool to encourage people to continue taking their medicines, because if a cure comes along, I sometimes say it may not be in my lifetime, but it could be in yours, that you would be eligible for a cure. That's something, yeah. And as I say, there are various techniques they're thinking of, and their approaches to cure. And so far, and some of them have been promising, but again, as I say, the bone marrow transplants and things like that are very alluring and things like that, because you could show that a person was cured, but the means to the cure is almost could kill you. Yeah. And most of these patients were actually dying of leukemias, and they happen to get, they happen to be, and they volunteered to do this because they didn't know whether there would be any success, but they did, and it was amazing that it was a proof of principle. But now in application, of course, that's going to be a much different thing. Yeah. Did I answer your question?
Yes, no, definitely.
Okay.
And then just one other question, then I'll open the floor up again. As far as early treatment, you need early diagnosis.
Yes.
know David spoke about self-testing, yet there are barriers to access to self-tests, as
That's
not
right.
all insurance providers pay for these self-tests. They're expensive. So what role do we see moving forward in thinking about equity and access for all? Does self-testing play in the full picture? Because if we could identify early, treat early, there's some chance of knocking down this latent reservoir.
Yep. No, I agree. I think that would be obviously a very, a very good avenue to address or to aggressively pursue. In terms of early diagnosis. The thing is, probably, as I say, making home tests, so it's so people can actually do it in the where they can do it in a private manner, and then working on ways to where they could easily link up in care, with so generating those. I think what happens is that oftentimes we get stuck in silos. So the early testing, and then the care centers and things like that may not fit that well together. But I think you're right. Obviously, if you're going to treat early, if that's one of the strategies to decrease the latent reservoir, would be to treat as early as possible. And then obviously you need diagnosis. There is the other thing that they're doing, of course, is rapid initiation of therapy, which is ongoing and now is now part of clinical practice. I didn't speak about it, but trying to actually get ARVs into people's hands and mouths as quickly as on the same day that they're diagnosed. So I guess we're getting maybe a little closer to that, maybe to that goal or that place. So that's I guess that's I didn't bring that up, but the rapid initiation treatment seems to be a very promising avenue to get people rapidly into treatment. Because on average, if you look at the data, typically it's about the standard way. Usually it's about 3 to 4 weeks between diagnosis and treatment. And that's actually, and sometimes it may be longer because, you also have to meet the patient where they are, of course. That's always, of course, because having an HIV diagnosis, sometimes people are not ready to start treatment. It really has to be individualized as well.
And that's really where the role, I think, of, partnering with the community and community health workers who come into place to help with this transition into the healthcare system.
Yes.
Just putting a plug out there.
Yep, indeed. Yeah. That would be crucially important. Yeah.
Any other questions? I know everybody is on mute because you were muted. Questions could be typed into the chat.
They can unmute themselves, Dr.
Okay.
Navarra.
Ann-Margaret, Tony Hines here.
Hello, Tony.
I just want to say very quickly, I have an 8 o'clock Zoom that this coming from where you and I started and where we are now, this is so overwhelming for me because I've been so removed from all of this. But it is still fascinating to know that we continue to try, and there are so many efforts throughout the globe trying to eradicate this virus. And I am sorely moved by the presentations and all of the data. It's overwhelming. But I just wanted to congratulate all of you for all of the work that you do. Thank you and God bless. But I gotta go. I have a Bible study at 8 o'clock.
Okay.
Thank you.
Thank
you,
you.
Tony.
Thank you for your kind words.
Yeah.
Any other comments, questions? I know we're a little over time, but we will stay if there's any questions. I know it's very comprehensive, so there might not be any questions left. Okay, well, I'm gonna, what I'm gonna do is I will stop the recording at this time.